Mr. Chairman, ladies and gentlemen, God, do I wish that I was giving this presentation face to face. The topic that I've been given is, can transplantation improve survival rates for older patients with higher risk MDS? These are my disclosures. Before I start, I thought I'll present the case history. A patient that I saw recently, or I was involved with, a 70-year-old man who at the time of diagnosis a few months ago had an IPSSR score of 4.5, intermediate risk. He was a heavy smoker, he had ischemic heart disease, he had type 2 diabetes, he had hyperlipidemia and benign prostatic hypertrophy, and hepatitis B core antibody positive, with long-standing history of hidradenitis suppurativa, which was related to myelodysplastic syndrome. In addition, he had morbid obesity of a BMI of over 44, and as expected, fibroscan showed increased resistance in the liver. CT scan had shown evidence of old TB, so he had a fair number of comorbidities. He had started 3 years previously with slowly evolving thrombocytopenia, had a number of investigations, and that showed marrow features consistent with MDS, with trilineage dysplasia, with DEL20Q and U2AF mutation, with a VAF of 8%. His disease progressed relatively quickly over a 3-month period, and then he was on June the 13th, he was started on venetoclax, 100 milligrams, and azacitidine for 7 days and venetoclax for 21 days. Following one course, blast cells dropped to 7%. And on the second course, which was given a month later, he was in morphological and cytogenetic complete remission. He received an HLA identical transplant from his fully HLA compatible and ABO matched sister, who was around 60 years of age. And for graft versus host disease, he had tacrolimus and methotrexate, or methotrexate on day 1, 3, and 6. He received fludarabine and triosulfan with subcutaneous Campa, 30 milligrams as conditioning. He obtained good engraftment. He had no complications post-transplant, and he was discharged from the hospital. Day 60 post-transplant, as you can see, his myeloid chimerism was 100%, but his lymphoid chimerism, which had been around 82% previously, started to drop. So he had a reduction in the FK506 to see whether his chimerism would increase. The case is from King Faisal Specialist Hospital, patient of Dr. Hazal Zaharani and others from Riyadh. Now, the key question is, would you have transplanted this 70-year-old man with significant comorbidities? I will go over some of the areas in terms of what selection was made, both in terms of donor as well as in terms of conditioning, etc., in this particular case. By way of introduction, as you know, there has been a significant increase in the transplant activity worldwide. This is the data from the US, and there's similar data from Europe, consistently showing that the number of patients that are being transplanted who are over the age of 60 is increasing, and the increase has been mainly in the matched unrelated donor transplants. And the increase has been predominantly in acute myeloid leukemia, and to a certain extent also in myelodysplastic syndrome. Although that said, that if you look at the European data, 7,000 patients with AML had transplants, whereas only just over 2,000 with MDS had transplants. So there is still a little while to go before the transplants in MDS catch the transplants in AML. One of the main reasons for that is age. And the question always has been, is chronological age a significant factor in terms of outcome after HSCTs? Some of these older studies, they're more than a decade old now, they all have large numbers of patients, one from EBMT, one from IBMTR, one from GITMO, all of them showing that it was disease-related factors that were more important in transplant outcome than the age itself. The other question has been, should we continue giving 5-azacitidine in older patients because there isn't clear evidence to show the transplants are better than 5-azacitidine? So this particular survey that was done has shown that in relation to large number of transplants, that the outcome, 3-year adjusted overall survival in patients who have received allogeneic transplant is no different in patients who are between the ages of 55 and 64 versus 65 to 79 years of age. And this, however, is not corroborated by the EBMT study, which on again a similar number of patients with similar spread of patients who have received RIX and MAX, and shows again that the HCT and Karnofsky and increasing age are all factors that go with prognosis. So at the present moment, in the absence of chronological age being a factor, there clearly is a need to identify other performance status factors that might better inform whether a particular patient is at a high risk if you were to give transplants to them. And there have been a number of these performance status scores from HCT-CI, which is most widely used, to, I think, still the case that the physician assessment remains the best selector in terms of identifying transplant eligible candidates. However, this area needs to be looked at in detail so that we can better identify patients at an individual level in terms of what complications they might have if they are to receive allogeneic hematopoietic and transplantation. That said, though, with advances in reduced intensity condition transplant, these kinds of factors might become less important than they were previously. So in terms of what are the transplant considerations that you keep, they are to disease-related factors related to the conditioning and related to post-transplant treatments now. So what are the factors that you need to take into consideration prior to transplant in terms of disease-related factors? One issue before that is whether or not transplant versus 5-azacitidine, for example, is there an advantage in doing transplant? There have been 2 excellent studies, one from US, one from Germany, all multi-center studies. US study involving around 384 patients between the ages of 50 to 75, with about 2/3 of patients having donors, because the selection, whether as a biological assignment on the basis of donor, no donor status, and 124 of these patients had Viron-AZA supportive care. And what both of these studies show that there is at least a 20% improvement and a statistically significant improvement in overall survival in patients who are receiving HSCT as compared to continuing with azacitidine and supportive care. And the US study also shows that there is a reduction also in leukemia-free survival. This has also been shown in another French study, which again is around 162 patients, again in older subjects, showing a statistically significant overall survival in favor of an allogeneic transplant rather than continuing with epigenetic therapy. The other issue is the IPSSR. Does it predict for outcome after transplant? It seems to, because lower risk transplant patients, lower risk IPSSR cases do better than patients who have a high risk or very high risk IPSSR, both in relation to overall survival as well as in relation to relapse. The question is whether other prognostic systems, particularly integration of the molecular into the prognostic system, will help identify patients who are at a higher risk of relapse following allogeneic transplant. Remains unclear at the present moment, but there have been 2 excellent studies that have been reported recently, which all show that molecular integration into IPSSR can take place. To a certain extent, we have also known for some time now that the remission status matters prior to transplant, that the lower the disease burden at the transplant, the better the outcome after the transplant. So it's not only IPSS low categories that do well. As you can see from this slide, those patients who are in CR, they do better in transplant. In fact, they do as well as IPSS low category following an allogeneic hematopoietic stem cell transplant. So the question has been, what are the regimes that are available at the present moment as bridge to transplant, and also whether you can get a deeper remission with some of these regimes that are available. And the backbone of these has been either 5-cytidine or decitabine, and these have recently been combined with venetoclax. And there are other venetoclax regimes, and there are other regimes which are in clinical trials, like anti-CD47 and SERP-alpha inhibitors, TIM3 inhibitors with azacitidine and venetoclax. So it is likely, as time goes on, that we will be able to achieve better complete remissions, and in some instances, probably cytogenetic as well as molecular remissions in patients going into transplant. What has been shown previously is that as far as molecular genetics in patients is concerned, that TP53, JAK2, and RAS mutations are associated with poor prognosis because of poorer overall survival and a higher risk of relapse. And in relation to TP53, there doesn't appear to be a difference in the various conditioning regimes, but it does appear to be significant in favor of myeloablative condition for the smaller number of patients who have either JAK2 or RAS mutations. Similarly, other studies have shown that in addition to TP53, DNMT3 and TET2 mutations also go with overall survival. What in the context of TP53, it's relevant to note that there is a difference between multi-allelic TP53 mutations, where as in comparison to monoallelic mutations, because the outcome of monoallelic mutations doesn't appear to be different to those who have wild type P53, whereas with multi-hit, the outcome is quite poor. Whether the same applies in the transplant setting is still unclear, but it is an area of increasing investigation. The other issue relevant, for example, in this patient was older sibling. There have been a number of studies that have shown that improved survival in older MDS patients with the use of younger unrelated donor transplants, both from EBMT as well as from IBMTR. Earlier studies had shown that aged donors have a higher risk of graft versus host disease, but there's been some conflicting data around it. And there is also some suggestion that there may be, as a result of impaired B cell and T cell and NK compartments, decreased T cell diversity, and therefore lower graft versus leukemia effect in in patients who receive transplants from older subjects, and also that the stem cell reserve may be lower in older patients than younger. There have been two excellent studies in relation to clonal hematopoiesis. One is this German study, which was in related HSCs over the age of 55 using 66 gene panel. And what it shows that there was a dominance of DTA mutations, which occur in about 16% of donors. What is interesting is that this study showed that there was a higher incidence of chronic graft versus host disease in patients who received transplant from clonal hematopoiesis donors. But at the same time, there was a lower incidence of cumulative lower incidence of relapse and progression in patients who received transplants from donors with clonal hematopoiesis. This has been extended recently in a larger group of patients or donors over the age of 40 using error-corrected sequencing, therefore to look at variable allele frequencies of less than 1%. These authors also looked at cytokine levels in 256 patients, and assessments were done at 6 and 12 months. Again, what it shows was that clonal hematopoiesis occurred in a fifth. DTA mutations were common and increased with age to about 41% in patients over the age of 60. What again this showed is that if you had a VAF of more than 1% for DTA and DTNM3A, that there was a higher incidence of graft versus host disease, particularly chronic graft versus host disease, but this does not apply to post-transplant cyclophosphamide conditioning. There was also a higher incidence of IL-12P70 in these patients, and 7 patients developed donor-derived leukemia, and they had mutations of the usual suspects, TP53 spliceosomes and DD40X1 gene mutations in the patient. So the inference is there is no reason to exclude donors who have clonal hematopoiesis. Rick versus Mac, this study now published 4 years ago, showed that in 129 patients assigned 1-to-1, there was no difference in overall survival, relapse-free survival between those who received Rick versus those who received Mac. There's been a significant advance, I think, in terms of introduction of triosulfan in the conditioning regimes. As you can see here, large numbers of patients, 476, who received either busulfan or triosulfan conditioning. And what you can see here is that 2-year event-free survival is significantly better with triosulfan, and the transplant-related mortalities is significantly lower in triosulfan conditioned patients. So it would appear that going forward, triosulfan conditioning reduces both transplant-related mortality as well as increases the event-free survival. This has also been shown in an update recently of large numbers of patients. 367 of them received fludarabine triosulfan as opposed to the usual RIC and MAG conditioning. Again, FT performed better in terms of overall survival. What is also interesting is that FT conditioning, that is fludarabine and triosulfan conditioning, did as well in terms of 5-year relapse rate as myeloablative conditioning at around 25%. Therefore, this kind of data argues about using these kinds of conditioning regimes based on triosulfan rather than myeloablative conditioning in older patients who tolerate intensive chemotherapies poorly and who have higher incidence of graft versus host disease following high-intensity transplants. So the final point in relation to selection of donors is haploidentical transplants. This has been a huge advance in terms of identifying the donors. As you can see from this EBMT data, haploidentical transplant outperform mismatched unrelated donor transplants and cord blood cell transplants. As a result of this, I showed you earlier on that cord blood transplantation throughout the world has decreased in MDS. The question has been about in vivo T cell purging, and as you can see from this data from Nicholas Kruger's group, which is that in terms of T cell depletion with ATG significantly reduces the incidence of chronic graft versus host disease. As you can see here, that those who received ATG had a 32% chronic graft versus host disease, as opposed to 68.7% who did not receive ATG. And we have shown exactly the same using Campath rather than anti-thymocyte globulin, where with Campath, the overall complication rate tends to be much lower. There are still a number of issues that are still clear, particularly in relation to mixed chimerism and what it might mean, and whether or not that has an effect on use of early donor lymphocyte infusions in the post-transplant period, because it is still the case that relapse remains the big risk post-allogeneic transplant. So the question has been, is there a uniform strategy post-transplant? One thing which is clear is that we need to have some handle on markers of minimal residual disease, because this particular study, for example, showed that if in the context of molecular markers, that it matters whether or not you had cleared the disease day 30 following transplant, because if you did, then the outcome of those patients was significantly better than those who did not clear their mutations. And this has been shown again in the context of Azalea's trial, where 5-azacitidine was used in those patients who had immunological evidence of residual disease following an allogeneic transplant. That said, though, there are a number of strategies that are being evaluated at the present moment post-transplant. They go with 5-azacitidine at a lower dosage, or oral 5-azacitidine with or without venetoclax, checkpoint inhibitors, panabinostat, and so on. King's regimes have predominantly been on preemptive DLI as soon as there is a reduction in the CD3, donor CD3 cells, with or without 5-azacitidine. And there are a number of other strategies that are being evaluated at the present moment, including antibody-mediated therapeutics with DARTs and BiTEs. And where they will fit in the post-transplant period remains unclear, which is quite relevant to the case that I presented, so which I come back to, which would be, would you have transplanted this 70-year-old gentleman? And did we do all the right things in terms of the conditioning we chose, the donor we chose, and did we do the right thing that we transplanted him? Thank you very much for your attention.